for today's Journal Club, I'm delighted that we're joined by Dr. Deniz, who's an assistant professor of radiology from New York University. He received his PhD in biomedical imaging from NYU, and his research focuses on integrating technical advances in deep learning with diagnostic radiology, specifically for musculoskeletal disorders. He's done a lot of great work for predicting the progression of osteoarthritis and osteoporosis fracture prediction. And today he'll be sharing some of that work on trying to predict total knee replacement using knee radiographs. And this was an article that was recently published in Radiology. And we're very excited to hear more about this. So Jem, please take it away.
Oh, thank you very much. Thanks for the introduction. And I'm very happy to be talking about my journal article here as well. And today, as Akshay talked about, I will be talking about our recent Radiology journal article. The title of the journal article is Prediction of Total Knee Replacement and Diagnosis of Osteoarthritis by using deep learning on knee radiographs. And we use data from the Osteoarthritis Initiative for this work. So you can see we have a collaboration with Downtown NYU as well as NYU School of Medicine. Also, there was an editorial by Dr. Richardson for this article. I found it very interesting and informative just to read after the publication of this article. So if you are interested on this type of work, it will be great if you can take a look at that editorial as well. So when we talk about knee osteoarthritis in the United States, there are about 40 million people aged over 25 or older have symptomatic knee osteoarthritis. So the surprising thing is more than half of the diagnosed people with osteoarthritis will undergo primary total knee replacement before that. Currently, there is no approved disease-modifying agents are available. There are some of them in the, we are expecting for it, but they are not approved yet. So each year, more than 600,000 total knee replacement surgeries performed, and this costs around $10 billion in healthcare spending. The diagnosis of osteoarthritis is done using clinical measures. One of them is questionnaires filled by clinicians and the patients. And the WOMAC pain score, the clinician is clinically assisting the patients to see how their joint pain feels, how their joint, if it's stiff or not, if there are any functional limitations. And there's another score, which is questionnaires from the patients, quality of life scoring system. Patient just goes and then fills up a questionnaire, and then that will enable us to assess the quality of life of that patient. When we get the radiographic diagnosis of osteoarthritis, there is a grading scheme defined with Calgren-Lawrence grading scheme. You can see, depending on the severity of disease, it can get from 0 to 4 grades. And 0 means normal, no features of osteoarthritis. And when we go to severe cases, the grade increases. To define the radiographic knee osteoarthritis, KL grade should be more than 2. In a separate system, in ORC Atlas, this kind of radiographic assessment is done based on assessment of osteophytes and joint space narrowing. So these methods, some of them are semi-quantitative, some of them are assessments in the clinical measurements, do not provide enough comprehensive information to make a robust and accurate outcome predictions. So because of this reason, the primary aim for our study was to develop a deep learning model for predicting the risk of OA progression. So for this one, we use knee radiographs from patients who underwent to TKR and matched control patients who did not undergo TKR. Secondary aim for our study was the automated prediction of KL grade from these radiographs. So we started our study with cohort selection and outcome definition. In the Osteoarthritis Initiative, there are more than 4,000 patients involved in the study, and they are taking measurements within the 9 years of period. So from the first enrolled patients, we have seen that 63 patients were received a knee replacement at the baseline. So we didn't include them into our cohort. After that, not inclusion of 63 patients, we moved to the cases. So whoever received a knee replacement during the study is taken as a case. And the partial knee replacements were not taken into account. So ultimately, we end up 376 cases who receive a total knee replacement during 9 years of period. And in terms of looking at the controls, we have seen that some of the patients were missing from the 9 years visit, so we just neglected those. And we make sure that they don't have a knee replacement at the 9-year visit. So 4 patients were missing a baseline information, and using this control group and cases, we did one-to-one matching with respect to sex, ethnicity, and age, with some additional constraints on the BMI. Our matched case control pairs resulted in 700 to 728 patients. So the patients, as I mentioned before, is defined as who underwent a total knee replacement in either knee after the baseline enrollment date within 9 years. So these are labeled as ones. And control patients who are appeared at the 9-year follow-up visit and did not go on total knee replacement in either knee. And we labeled them as 0. So we're looking at the binary classification problem to distinguish patients from control patients. So images come in different resolutions and different sizes. The first thing in image preprocessing we have used was bring the resolution to the same. So we use 0.2 by 0.2 millimeter square resolution. And using the bounding box information from another study, we extracted left and right knees with a size of 1024 by 1024. So this processing step was done for all the cohort of 728 subjects. Once we have those images from subjects, either left or their right knee, this is the deep learning model training scheme. So the training set involves these images. And we use additional image processing, basic additional image preprocessing step, where we use zero mean and unit variance scaling of the images. And as a deep learning model, we use ResNet-34 architecture. And we had multiple tasks. As you remember, our primary aim was to define binary total knee replacement outcome within 9 years. And secondary aim was to predict the KL grade of these images. So these will provide labels to a loss function, which is the cross entropy for our case. And we trained this model, updating the model weights. Once we decide on the model, when we finish the model training, we use those weights in the test set and evaluate our model's performance. In the test set, during the performance evaluation, we use center cropping and did the same image preprocessing step and used the weights from the model training. And as a result, we will obtain the TKR outcome, kind of probability, and the KL grade of that image of that knee. So in order for us to enable image input for the size of 1024 by 1024 and our output labels, we need to do some architectural changes in the ResNet architecture. So this is the original ResNet architecture. As we can see, the image gets into from the left to the right, and it's processed by multiple convolution layers. And at the end, there's an average pooling and a fully connected layer of 1,000 classes, where ImageNet has 1,000 classes. So the first thing we changed was the kernel size of the average pooling operator. We changed the size from 7 to 20. So this enabled us to use input images of size 1024 by 1024. As a second step, the fully connected layer was replaced by a fully connected layer of 2, since we are aiming to predict the binary total knee replacement studies from subjects. An additional multitask information, additional fully connected layer of size was incorporated to the architecture for KL grading task. The details of the deep learning model training is specified as here. The source code and the DL model for the study is also, we push the code to the our GitHub repository. In terms of optimizer, we use Adam optimizer with a learning rate 10 to the -4. This learning rate was obtained from a grid search. And we use 8 as a batch size and choose our model based on the validation accuracy within 200 epochs. We use some data augmentation as well during training. We did random left and right flipping with probability of 0.5. And we also did cropping the size of random crop of the images to a size 896 by 896. For training, we use nested cross validation on 7 disjoint groups of size 124 each. So I usually have most of the questions for nested cross validation. That's why I would like to talk a little bit about it. Nested cross validation is a scheme where we have outer sampling part and as well as the inner resampling part. You can think about these 2 loops, outer loop and inner loop. And the aim for the inner loop is similar to the traditional cross validation to figure out the models or parameters. So we can test that in an independent test set, independent test set where we haven't seen any of the test images during model development. So this is one way of using all the data and not to bias the test set during our training. And we did 7-fold nested cross validation. So instead of 3 folds shown here, we have 7 different folds or outer layers and 6 inner layers that we perform this cross validation. So to compare our deep learning model with other image-based prediction models, we define the KL model as if the subjects or if the images has KL grade higher than 2, we define the output label as 1. So this is the definition of radiographic OA used in clinics. And we define another model using the ORC grading. So we define the outcome label as 1 using the radiographic knee OA criteria. So it was either joint space narrowing grade 2 or greater, or there was some of osteophytes grades 2 or greater, or they were both, like we had joint space narrowing grade 1 and osteophyte grade 1. So these models, these binary models are used to compare our deep learning models' fidelity. When we look at the results in comparing the different image-based prediction models, we can see that semi-quantitative radiological readings has similar AUC, has similar binary outcome prediction capability. And also sensitivity and specificity is also in the similar ranges. And there weren't a significant change between these 2 grading schemes in this cohort. When we look at the deep learning model, which is trained from scratch, like using the random weights, we see that there's an increase in the area under the curve, and this increase was significant. We see also that increased bump in specificity, but there was a decrease in sensitivity. We have tried transfer learning as well to this deep learning model. And we used the transfer learning model weights from pre-trained ImageNet model, pre-trained model from ImageNet dataset. You can see that using pre-trained model improved our AUC from 0.84 to 0.86 and improved the sensitivity as well. As a last step, we incorporate the information of multitask learning from KL grades, semi-quantitative KL grades. The area under the curve is improved, but there was a shift between the specificity and sensitivity. So we obtain a higher sensitivity and lower specificity with respect to the previous deep learning models. So to see things a little bit visually, we use zombie plot to compare these outcome prediction models. You can see this plot shows different zones highlighted by gray or white or darker grays. And the optimal zone is defined as the white region here. So in this region, if our predictors or prediction model sits in this region, that means those are credible predictors for deciding on the TKR outcome. You can see that the current semi-quantitative readings are not sitting in this optimal zone, but they are still in a zone where they can be used to predict outcomes. Later, we look at where the deep learning models put attention or take the information from which regions. So in the first row, you see the different control and patient subjects with different KL grades. And on the bottom, you see the heat map of we generated using Grad-CAMs, showing that where the deep learning model gathers most of the information to predict if the image is from a control patient or a patient. So we can see from these patient and control heat maps that deep learning model learned features related to the knee joint or bones to classify the samples between these two groups. So this provides us some idea about where the deep learning models are focusing on, and we are working on interpreting these results or interpreting the deep learning models in a superior way than just looking at the heat maps and the regions. This is like a check mark to say that, okay, so the deep learning model is also looking at regions where the radiologists are interested in. When we look at the confusion matrix for KL grade prediction task, we see that the radiologist-defined KL grades can be predicted very well for KL grades or for the disease when it's getting severe, but it's not the case for KL grades of 0, 1, and 2. When we look at the area under the curve values for different grades, this is also visible very well. You can see that the KL grade 4 is very high likely to be predicted correctly by the deep learning model. However, the hardest one of the KL grades was KL grade 1. You can see the area under the curve is much lower than the other ones. So our model trained with multitask learning predicted the KL grades at levels acceptable, comparable to the radiologists. So when we compare with the radiologists, Cohen's kappa coefficient was 0.78. It was pretty good, as well as the mean square error was low and the multiplex accuracy was good, high enough. Once we have deep learning predictions, we use statistical analysis using conditional logistic regression to assess the risk of the total knee replacement. So first, we have worked on compared if multitask learning approach improved the quality of total knee replacements or not. As you can see from the adjusted odds ratios, the improvement in the adjusted odds ratio using multitask learning was predictive of that we are getting more information by combining two tasks together. And we use crude odds ratio is defined as when there's only one predictor, which is for this case, deep learning model's outcome. And adjusted odds ratio is when we are taking all kind of other information, which I will show in a second, other risk factors, what will be the odds ratio for that model. So these are the other risk factors. So semi-quantitative KL grade readings or ORC readings and BMI. We can see that these are the odds of total knee replacement increased with an increase in KL grade and BMI. So you can see that odds ratio is larger than 1, even though it's not so large than 1. And for ORC grade, even though the crude odds ratio was very high, when we take care of the other risk factors, the adjusted odds ratio for ORC grade is attenuated. And when we look at the clinical measurements, the risk of total knee replacement was not strongly associated with either quality of life score or WOMAC pain score. So there was a very minor association, I can say, with quality of life score. Also, the risk factor for total knee replacement is the contralateral knee. And we looked at also the information in the contralateral knee in terms of WOMAC pain, how painful was the knee, and also the semi-quantitative radiological readings. So we have found that the contralateral knee measurements were not associated with the risk of the total knee replacement in our case. So there were other risk factors which are studied before, and we also studied in this work. One of the issues with that was we didn't have all the measurements for all the subjects. That's why we did additional analysis for different number of subjects for different risk factors. Here we can also see that the different risk factors, for example, if the family has a knee replacement before, or if the subject has a previous injury, and the joint space width, what was the minimum joint space width. And Haberden node is also related to hand osteoarthritis on that. So we have seen that the odds of previous injury among patients were lower than the odds of previous injury among controls. So you can see it here. The other risk factors, when we look at the adjusted OR, were not highly associated with the total knee replacement risk. So coming to a conclusion, so we have shown that a multitask deep learning model can accurately predict the osteoarthritis progression in patients who will require a knee replacement within 9 years. And odds ratio was really high and significant. In terms of KL grade predictions, our model outperformed other outcome prediction models based on standard grading systems. And when we look at how acceptable our KL grade predictions were compared to the human graders, it was better than previous studies. In terms of future work, we used only the baseline patient information to predict the risk of total knee replacement in our study. So Osteoarthritis Initiative dataset has also clinical observations and radiographic readings over subsequent years, and changes in those may affect the patient's decision to undergo a TKR. So this can be also incorporated in future studies. In addition to knee radiographs, the Osteoarthritis Initiative dataset includes knee MRIs as well. And we have seen, or we are working on different deep learning models using three-dimensional MR images that could be also used to predict the knee osteoarthritis progression. And there are several groups that are doing it. We have been doing this as well. And in the study, we didn't use any MRI information. In terms of limitations for our study, the dataset size was limited for training a deep learning model from scratch, even though deep learning model from scratch provided better area under the curve compared to the semi-quantitative readings. And the dataset size was also limited for using traditional train validation test set splits. Because of those reasons, we used transfer learning and nested cross-validation. We define the total knee replacement as a binary variable, and this is neglecting the association from the time from the baseline to the time of total knee replacement. So this can be also studied, but the dataset size could be also impactful for the accuracy of those models. And we define a single clinical outcome variable for undergoing a TKR within 9 years. And there are decision to undergo a TKR can be affected by other factors like comorbidities or insurance status, or the patient or subject may be afraid of going in under a surgery. I would like to acknowledge our NIH funding and also the NIH funded OAI data acquisition and through the years. So I would like to acknowledge their support in this type of research. And I would like to thank you for your attention.